Welcome back, guys. Now in this video, let's discuss about the topic of preterm labor. Guys, let's see some important definitions. When we are going to call the pregnancy is a term pregnancy. See, 37 to 42 weeks. Okay, this period of gestation. If a period of gestation is continuing up to 37 weeks and also up to 42 weeks. See, anywhere between 37 weeks to 42 weeks is considered as a term. Okay, if pregnancy is continuing beyond 42 weeks means that is usually term is up to 42. If pregnancy is continuing beyond 42 weeks, then it should be called as post-term pregnancy. The same way, if pregnancy, or I should say the labor pains, if the labor pains are happening before term, that is before 37 weeks. If a female is experiencing labor pains with cervical dilation before 37 weeks, then it is known as a preterm labor. Preterm labor before 37 weeks or before 256 days. Okay, so this is the usually asked MCQ. Preterm labor means labor pains happening before 37 weeks. Now, before 37 weeks means it can be 34 weeks, it can be 33 weeks, it can be 36 weeks, something like that. So, in preterm labor, there is further classification. For example, if preterm labor is happening before 33 weeks means it should be called as early preterm labor. Or if preterm labor is happening between 34 to 36 weeks, or the labor pains are coming between 34 to 36 weeks. So, this is called as late preterm labor. Okay, after seeing these important definitions, now let's talk about the diagnosis. Okay, diagnosis of a preterm labor. See, when we are going to say that this female is having a preterm labor before 37 weeks, see, guys, the female should be having at least more than 4 contractions within 20 minutes. If a female is experiencing, okay, that is before 37 weeks I am talking about. If a female is experiencing more than 4 contractions in 20 minutes or more than 8 contractions in 60 minutes, that is 1 hour of time. Okay, in a 1 hour period, if a female is experiencing more than 8 contractions, we can say that she is in preterm labor. Okay, before 37 weeks, if she is having any of them, we will say that she is going into labor. That is preterm labor. There are more diagnostic criteria. Now let's see. See, cervical dilation more than 2 centimeters. Cervix is getting dilated. If cervix is getting dilated, automatically labor will happen, right? See, in the first stage of labor, the cervical dilation, cervical effacement will happen. That's what happening. If dilation of cervix is more than 2 centimeters and the cervical effacement is 80% happened, 80% cervical effacement is happened, we can say that she is going into labor. Okay, now you have done the ultrasonography, and in the ultrasonography it's very clear that the length of the cervix is less than 2.5 centimeters. Okay, the length of the cervix is less than 2.5 centimeters. We can say that she is going into labor. Okay, now fetal fibronectin is present in the cervico-vaginal fluids. Actually, this fetal fibronectin is the one which attaches the chorion to the uterus. Okay, actually it's functioning like a glue. Okay, actually in between the chorion and the decidua basalis, this fetal fibronectin is acting like a glue. Whenever the chorion gets separated, from the decidua, this fetal fibronectin will be leaked out, and this fetal fibronectin will be seen in the cervico-vaginal fluids. So, if you see the fetal fibronectin in the cervico-vaginal fluids, it's an indicative of impeding preterm labor. Okay, labor is going to happen. Okay, so these are the diagnostic criteria for the labor, preterm labor. So, in a female who is less than 37 weeks of period of gestation, you are seeing all these all these conditions like more than 4 contractions within the 20 minutes or more than 8 contractions in 1 hour. The cervical length is less than 2.5 centimeters and cervix is more than 2 centimeters dilated with the effacement of 80% and the presence of fetal fibronectin in the cervical vaginal fluids, especially more than 15 nanograms per ml. Okay, this much amount of fetal fibronectin in cervicovaginal fluids, all these are indicative that she is going into labor. Okay, she is going to labor. Now after this, let's talk about the causes of the preterm labor. The most important cause, okay, the most common cause of the preterm labor is idiopathic. This is the MCQ. Okay, now the previous history of preterm labor is also a cause of, is also a risk factor for current preterm labor. See, the most common cause is idiopathic. We don't know why it's happening. Other causes include previous history of preterm, infections, very important point. If a female is having infections, such infections can cause chorioamnionitis and that chorioamnionitis can lead to preterm labor. Now important point is, what are the organisms which are responsible for chorioamnionitis? What are the organisms which can cause chorioamnionitis? The most common organisms include Gardnerella vaginalis, okay, ureaplasma, and also you can see here, these are the organisms which can cause the chorioamnionitis. Ureaplasma, ureolyticum, Gardnerella vaginalis, chlamydia, gonorrhea, E. coli, mycoplasma, all of them can cause chorioamnionitis. And important point is, infections are a risk factor for preterm labor. Infections can lead to preterm labor. Very important point. Now, there is this female who came to you and you are suspecting infection or chorioamnionitis is happening in this female. So how to put the diagnosis of chorioamnionitis? Because if there is chorioamnionitis, that will lead to preterm labor. So first you have to confirm yourself that there is this chorioamnionitis. So you have to check these things. See, presence of any of the, at least if you have to have 2 of the following. See, if there is foul smelling vaginal discharge or increasing in the WBC count, leukocytosis. If the female is having this foul smelling vaginal discharge or leukocytosis, increase in the CRP, C-reactive protein, more than 2.7 milligram per deciliters, increase in the pulse rate of this female, uterine tenderness, all of these are suggesting that she is having chorioamnionitis. To put the diagnosis of chorioamnionitis, out of these, at least you need to have 2. So once you put the diagnosis of chorioamnionitis, you are going to treat it accordingly with the antibiotics. So what I am trying to put into your mind, infections can cause preterm labor. The most common cause of preterm labor is idiopathic. Okay, well and good. Now let's see some other causes of the preterm labor. Why preterm labor can happen? Other causes include, see, uterine overdistension. See, uterine overdistension is a condition which is associated with, for example, polyhydramnios. Okay, polyhydramnios or twin pregnancy or multifetal gestation. So uterine overdistension is seen with twin pregnancy or polyhydramnios. So if someone asks you, twin pregnancy is a risk factor for preterm labor, yes, true. Polyhydramnios risk factor for preterm labor, true. Cervical incompetence. We all know that cervical incompetence is a condition where there is a painless dilation of cervix. If cervix is dilating in second trimester, do you think pregnancy will be continued? No. So in second trimester, painless cervical dilation can lead to abortions. In the same way, having cervical incompetence is also a risk factor for preterm labor. Now, see, cervical incompetence, for example, why there is cervical incompetence? Might be because of a small cervix. Okay, if a female is having small cervix, see, cervical incompetence might be because of small cervix. What exactly is small cervix? We have already discussed. A cervical length less than 2.5 centimeters. That's the MCQ. If she is having a small cervix, such small cervix can be easily dilated and easily effaced. So, preterm labor can happen. Now, cervical surgeries. Okay, now you might ask me a doubt. For example, if there is cervical incompetence, to prevent preterm labor, what we do? In cervical incompetence, there is painless dilation of the cervix. So to prevent this dilation, what we can do? We can put a cerclage. That's what we will do. Okay, we will discuss in the management. So cervical surgery is like cervical conioization. Okay, conioization or cervical lacerations can lead to preterm labor. True. Now, preeclampsia in a female, antepartum hemorrhage, uterine anomalies like septate uterus, bicornuate uterus can cause preterm labor. And previous history of preterm labor is also a risk factor. We have already discussed. Okay, previous history of a preterm labor is a risk factor for current preterm labor in the female. So after this, now let's discuss about the signs of predicting the preterm labor. Okay, there is this female. Imagine that there is this female who came to you. Now, she is saying you that, doctor, previously I had a preterm labor. My previous pregnancy is complicated with preterm labor. Now, what you have to do? You have to check whether there are any signs that giving you information about prediction for the preterm labor. Now, in this female, now she is at risk of preterm labor. Now, what are the signs you will examine that is she still at a risk of preterm labor? Now, let's see. See, if she is having short cervix, it's a prediction that she will go into preterm labor. If she is having a small cervix, you have to think about that. She may end up in preterm labor. Funneling of the cervix. See, by 29 weeks, okay, if you do ultrasonography, now you are seeing that the bag of membranes, okay, the amniotic membrane, it is slightly coming into the arse. Okay, it is coming into the arse. So that is known as funneling of cervix. If you notice funneling of cervix, now she is at a risk of preterm labor. See, now you can predict that preterm labor might happen. She will have the labor pain. She will have cervical dilation, uterine contractions before 37 weeks. Okay, before term. Important. Now, the presence of fetal fibronectin in vaginal secretions. Actually, please take this point. Before 22 weeks. Okay, before 22 weeks, normally, fetal fibronectin is seen in the cervico-vaginal secretions. That's something normal. Before 22 weeks, normally fetal fibronectin is present in the cervico-vaginal secretions, and this fetal fibronectin is also going to be seen during the term. So after 37 weeks, it is normal to see fetal fibronectin during term. Okay, this is something normal. But if you see this fetal fibronectin in vaginal secretion between 22 to 37 weeks, it's a prediction that she will end up in preterm labor. Okay, so please concentrate here. If you see this, a fetal fibronectin in between this particular time, almost 30% of the females will end up in preterm labor within a week. Okay, after seeing this fetal fibronectin, after fetal fibronectin is coming positive, 30% of the females will end up in preterm labor within 1 week after this fetal fibronectin positive, and 40% of the female will end up in preterm labor within 2 weeks. Okay, that's an important point to know. Now, how to prevent preterm labor? Now, you got certain predictions. Now, you are thinking that this female will most likely end up in preterm labor. So, what you have to do? You have to prevent it. So, how you are going to prevent it? So, the prevention of preterm labor is done with the progesterones. Okay, progesterones will be given to this female that can prevent preterm labor, and the progesterones are drug of choice for preventing preterm labor. See, once if there is a preterm labor, these progesterones cannot do anything. Progesterones does not have, please take this point, progesterones does not have, okay, they does not have any role, okay, they does not have any role in preterm labor. Means once if there is preterm labor, these progesterones are not helpful, but the progesterones are drug of choice for preventing preterm labor. Okay, so for example, there is this female who is having a short cervix. Okay, there is this female with a history of preterm labor. Now she is having a short cervix. Now, if you don't intervene, again the short cervix will be easily effaced and easily dilated. That can lead to preterm labor. Now, what you have to do to prevent this preterm labor in this female with a short cervix? What you have to do? You have to put a 𝗍𝐼𝐻. So, 𝗍𝐼𝐻 can be kept, that 𝗍𝐼𝐻 will be there, right? So, 𝗍𝐼𝐻 can be there, like you can keep it, or McDonald 𝗍𝐻, most commonly used 𝗍𝐻. Okay, McDonald 𝗍𝐻 or 𝗍𝐼𝐻, it can be kept. Important point is when you have to apply the 𝗍𝐻. Okay, when you have to apply the stitches, the 𝗍𝐻 should be kept between 13 to 14 weeks. Okay, it should be kept between 13 to 14 weeks of gestation. And when you have to remove the 𝗍𝐻, so the ideal time to keep the 𝗍𝐻 is 13 to 14 weeks. After 12 weeks, you can keep this, these stitches. But when to remove the 𝗍𝐻 should be removed after 37 weeks. Okay, it should be removed after 37 weeks only. After the term, you have to remove the 𝗍𝐻. Now, what else we can do? See, we can give prophylactic antibiotics. So, by giving them, why prophylactic antibiotics? Because they can treat the infections. If there are any infections, that infection will be treated. So, there won't be any preterm labor. Why? Because infections can lead to preterm labor. Okay, we have discussed, right? So, this is what we do for preventing the preterm labor. Now, what are the complications with the preterm labor? Okay, for example, there is this female who is going into labor at 32 weeks or 33 weeks. What are the complications? See, at 32 weeks, do you think that the fetus lung, the fetal lung have matured? No, the fetal lung maturation happens by 34 weeks. So, before 34 weeks, the fetus lungs are not matured. That causes respiratory distress syndrome. So, if a female is having preterm labor and delivery, that baby, whoever delivered, will have a respiratory distress syndrome because fetal lungs are not matured. Okay. So this is a problem. There are many problems, but the main important problem is fetal lungs are not matured. Now let's talk a few important normal physiological points first. See, for the maturation of the fetal lungs at 34 weeks, who actually helps? Surfactant. Surfactant will cause the maturation of the fetal lungs. And the surfactant is produced by type 2 pneumocytes or type 2 alveolar cells in the fetal lungs will start produce the surfactant by 34 weeks. Now this surfactant is the one which helps in the lung maturation. Now if I am saying lung maturation, what exactly I mean by? See, these surfactants are going to reduce the surface tension inside the lungs. See, these surfactants are going to decrease the pressure inside the lungs. So, surfactant decreases the alveolar surface tension. By decreasing the alveolar surface tension, fetal lungs will be matured. Now, absence of surfactant means before 34 weeks. Absence of surfactant leads to respiratory distress syndrome. This is the problem in the preterm labor. If labor is happening at 30 weeks, 31 weeks, not enough surfactant. If there is no surfactant, fetal lungs are not matured. Now, in this baby, lungs are not matured and the baby is going to suffer with hyaline membrane disease. Hyaline membrane disease, also known as a respiratory distress syndrome. Okay, this point is important. Hyaline membrane disease, respiratory distress syndrome, due to absence of surfactant. Now, after saying this, let's talk about a few points about the surfactant. This surfactant, it's actually made up of two main components. What are the two main components of the surfactant? The two main components are phosphatidylcholine and phosphatidylglycerol. Phosphatidylcholine and phosphatidylglycerol are the two main components. Out of these two, 80% is phosphatidylcholine only. Okay, now phosphatidylglycerol is just a 15 to 20%. Important point is, this phosphatidylcholine is going to be seen in amniotic fluid, seen in maternal serum, seen in fetal serum. Okay, so phosphatidylcholine is present in the baby, it's present in the mother, it's present in the amniotic fluid. But important point is, phosphatidylglycerol, this one, it's present only in the amniotic fluid. Phosphatidylglycerol, please take this point, present only in the amniotic fluid. This is the MCQ. Okay, and this phosphatidylglycerol, it is the final indicator of lung maturity. So we are going to check the levels of phosphatidylglycerol to know the fetal lung maturity, whether the fetus lungs are matured or not. How are you going to know that? See, by checking the phosphatidylglycerol. Okay, so now let's see what are the tests which we are going to do, whether the fetal lungs are matured or not. Okay, how to know whether the fetal lungs are matured or not? There are certain tests. Okay, these are very important. They will simply ask you all of the following tests are used for fetal lung maturity except. So you should know. See, lecithin-sphingomyelin ratio. See, if lecithin to sphingomyelin ratio, if it is more than 2, it indicates that the fetal lung maturity happened. Okay, this is a very important thing. Fetal lung maturity is known by seeing the lecithin to sphingomyelin ratio. If the ratio is coming more than 2, it indicates that fetal lungs are matured. Apart from that, see, the very important one I have said you, the phosphatidylglycerol, which is present only in the amniotic fluid. In the amniotic fluid, if you find this phosphatidylglycerol, then surfactant synthesis has happened, fetal lungs are matured. This is the best test. Okay, this is the best test measuring the phosphatidylglycerol in the amniotic fluid. Now there is this test called as shake test or bubble test. Okay, shake test or bubble test, which is actually a bedside test. What exactly we are doing is we are going to collect the amniotic fluid. And to this amniotic fluid, you are going to add some agents like saponification agents. You are going to shake. Okay, you are going to shake. So whenever you shake, if you can see the bubbles, then the fetal lungs are matured. If you can see the bubbles, if the bubbles are coming positive, it means the fetal lungs are matured. See, the surfactant is nothing but a lipid. Now to this lipid, which is present in the amniotic fluid, to this lipid, you add this saponification agent, it becomes like a soap. So whenever you shake, the soap is going to form bubbles. So when the soap is going to form? Soap will form when you mix a saponification agent with a lipid. That lipid is a surfactant. So whenever you mix this surfactant which is present in the amniotic fluid with a saponification agent, and whenever you shake it, it's going to form a bubble. So then you are going to say that bubble test is positive or shake test is positive, which is an indicator of fetal lung maturity. Now, after this, let's talk about Nile blue sulfate test, okay, or Nile blue phosphate test, which is also known as a skin test. Remember what we are going to do here. See, we are going to collect the amniotic fluid, and from the amniotic fluid, you are going to take the fetal cells, okay, the epithelial cells of the fetus. Now you have done the amniocentesis. You have collected the amniotic fluid. From the amniotic fluid, you have collected the fetal epithelial cells. Now, to these fetal epithelial cells, you are going to apply a dye known as Nile blue dye. Okay, Nile blue sulfate or Nile blue phosphate is going to be applied to these epithelial cells. And if these epithelial cells, if they are staining orange, if more than 50% of the epithelial cells, if they are staining orange, see, when they will stain orange? When means, see, the fetal epithelial cells, skin cells, if they contain lipids, they are going to stain orange. If fetal epithelial cells are having lipids, means the lipids are getting synthesized in the baby. Also, the lipids are getting synthesized in the lungs relatively. So, Nile blue sulfate test or Nile blue phosphate test, also known as a skin test, if more than 50% of cells are coming, if more than 50% of the cells are staining orange, means lipid synthesis is happening in the baby. Also, the surfactant synthesis is happening in the baby. So, once the surfactant is there, fetal lungs will be matured. The surface tension will be decreased. Okay. Now, there is one more test which is known as the lamellar body count. The lamellar bodies are the places where, okay, these surfactant is stored. This is not well done, but the other tests are very important. So they will ask you all of the following are the tests done for knowing the fetal lung maturity. You have to know that. Okay. Now after saying this, now what is the management? There is this female who went into preterm labor. You have, like, who is going into preterm labor. Now what you have to do? Okay, what you have to do? See, the management. What is the main problem, guys? If a female is in preterm labor, especially before 34 weeks. Okay, before 34 weeks, the main problem is that the fetal lungs are not matured. So what you have to do? you have to give steroids. Okay, you have to give steroids via intramuscular or intravenous route. You have to give steroids to this mother. Whenever you give steroids to this mother, these steroids are going to cross the placenta and going to enter into the baby. In the baby, these steroids will cause maturation of the fetal lungs. Okay, maturation of the fetal lungs. So maturation of the fetal lungs is achieved by giving steroids. What are those steroids which we usually give in India? It is a dexamethasone. In India, we usually use a dexamethasone 6 milligram every 12 hours. You are going to give 4 doses. Important, 6 milligram every 12 hours. 4 doses we are gonna give. Now in the rest of the world, okay, in the rest of the world, we are going to use beta-methasone. Okay, beta-methasone will be given worldwide. How much doses? You will be giving 2 doses, 12 milligram every 24 hours. Okay, 12 milligram every 24 hours for 2 times. Okay, 2 doses will be given. Guys, let me tell you one thing. There is this female who came to you with preterm labor. Okay, now today she came to you with the preterm labor. Guys, can you totally arrest this preterm labor? Can you totally halt this labor? No, you cannot. What I'm trying to put into your mind is, there is this female who came to you with the preterm labor. Now, don't think like, you are going to stop this preterm labor and going to continue the pregnancy till 37 weeks. That's not going to happen. You can't do something like that. What you can do is, you can delay the process of a labor. Okay, if she is having preterm labor today, okay, mild uterine contractions are there today. What you can do is, you can delay it for next 2 to 3 days. That's it. Okay, you can delay it for next 2 to 3 days. That's it. It's not possible to stop this preterm. See, this is a labor. Now, cervix is getting dilated. It's not possible to continue till term. Okay, what you are doing is getting some time. Okay, getting some time for the fetal lungs to mature. How you will do that? We will discuss. How to temporarily delay the labor. We will discuss. Right now, what we are discussing? We are discussing how to make the fetal lungs mature. How we are doing that? We are doing it by giving steroids, dexamethasone, beta-methasone. Okay, now, okay, there is this female who came to you with preterm labor. Already her cervical dilation is 8 centimeters. Cervix is 8 centimeters dilated. Now she is having uterine contractions. Now she is in labor. Now what you have to do? Now definitely you have to deliver. You shouldn't be able to, you cannot do conservation now. You cannot delay now. You have to deliver. So you have delivered the baby. Okay. Now what to do now? See, there is no time for you to give the steroids. Now what to do now? See, postnatally, after delivering, you can use artificial ventilation. Along with that, you can give this artificial surfactant. So artificial surfactant can be given via intratracheal routes. So via intratracheal route, after delivery, you can use this artificial surfactant. The most famous one is Cervanta. Okay, Cervanta is an artificial surfactant that can be used postnatally. But before birth, you can use dexamethasone or beta-methasone. Important point is, you cannot stop the preterm labor. What you can do is, you can only delay the process. How we are going to delay the process, sir? See, imagine, now she is having mild uterine contractions and her cervix is just 2 centimeters dilated or 3 centimeters dilated. Okay, just 2 centimeters dilated. What you can do to delay is the tocolytics. You can use tocolytic agents so that the process of labor is delayed. Okay, so you are getting hardly 1-2 days. That's it. So in this 1-2 days, you are expecting the fetal lungs to be matured. How the fetal lungs will be matured? You are giving these surfactants. Okay, that's the important point. Note, effect begins after 24 hours. Which effect? If you give the surfactants, for them to work, okay, for them to work, it takes 24 hours and the maximum effects will be seen after 2 to 7 days. Important point. Along with that, see, what are the contraindications for steroids? The steroid should not be given if the female is having chorioamnionitis. If a female is having chorioamnionitis, no steroid should be given. And preterm labor before 34 weeks, actually you give corticosteroids. See, before 34 weeks, lungs are not matured. So definitely you will give these corticosteroids for the maturation of the lungs. But if she is having a preterm labor, imagine that there is this female who is having preterm labor at 36 weeks. By 36 weeks, already fetal lungs are matured. Then are you going to give corticosteroids in preterm labor, which is happening by 36 weeks? No. Preterm labor after 35 weeks, corticosteroids are not given. Okay, that's a very important point. Now, see, the main problem is fetal lungs are not matured. So what you are going to do? You want the fetal lungs to mature, so you are giving the corticosteroids. Now, for the corticosteroids to act, it takes a time. So what you have to do? You have to delay the process of labor. For that, what you have to do? You will give tocolytic agents. Tocolytic agents. See, what is the purpose of these tocolytic agents? Are you going to completely terminate this preterm labor? Are you going to completely halt this preterm labor and continue the pregnancy till term? No. Just for 1 to 2 days. That's it. Okay. So tocolysis, okay, it gives us time for the fetal lungs to mature. Then we are going to deliver the baby. You can ask me, sir, how can we know whether the fetal lungs are matured or not? We have seen a lot of tests. Okay, that lecithin-sphingomyelin ratio and all that stuff. Okay, that shake test, bubble test, that phosphatidyl glycerol in the amniotic fluid. Those are the tests to know whether the fetal lungs are matured or not. Now, tocolysis. Now, tocolysis is given before 34 weeks. Okay, before 34 weeks. Why? Because actually, see, after 34 weeks, the fetal lungs are already matured. Okay, by 35 weeks, the fetal lungs are already matured. Then the tocolysis is not that helpful. Okay, see, usually we give, but tocolysis after 35 weeks is not that helpful. And also remember, tocolysis should be given only if the cervix is less than 3 centimeters dilated. Now there is this female who came to you with the preterm labor. Her cervix is 2 centimeters dilated or 3 centimeters dilated. Important point is, if you give tocolytics in this female where the cervical dilation is less than 3 centimeters. Now these tocolytics will work. But after 3 centimeters, you give whatever the tocolytic you want, labor can't be delayed, labor can't be inhibited. After 3 centimeters dilation of the cervix, you can't delay the process of labor. So tocolytics are helpful before 34 weeks. They can only work with a cervical dilation less than 3 centimeters. After 3 centimeter cervical dilation, you do whatever you want, you cannot stop the labor. Okay. So what is the important purpose of this tocolysis? Tocolysis will give enough time for the fetal lungs to mature. Now, what are the agents which we are using as a tocolytic agents? Guys, there are important drugs and important points about the drugs. See, now the first group of drug that we are going to discuss is a beta agonist. We all know that the beta 2 receptors which are present on the uterus, if you can stimulate that beta 2 receptors, the uterus will be relaxed. So, uterine contractions are going to be decreased. Relaxed uterus means tocolysis. So, what are the examples of beta 2 agonists? They are salbutamol, ritodrine, isoxazoline. Now, what are the important points about these beta 2 agonists? See, these beta 2 agonists, they are associated with hyperglycemia. They cause us lipolysis, and they are also associated with pulmonary edema. Important MCQs. See, hyperglycemia, lipolysis, and pulmonary edema. The above two, they are associated with the increased sugar levels. Okay, increased sugar levels. So, they can ask you which tocolytic agent is associated with the hyperglycemia, associated with the lipolysis, associated with the pulmonary edema. They are beta 2 agonists. They are salbutamol, ritodrine, and isoxazoline. After this, let's talk about the calcium channel blockers. We all know that the calcium is necessary for the contractility of the uterus. If you give calcium channel blockers, calcium is not available for the uterus, so the contractions are going to be decreased. So what is the example, guys? The example is nifedipine, very important drug. So this nifedipine is the best drug, best tocolytic drug is. The drug with maximum efficacy or the first line agent for tocolysis is nifedipine. Important MCQ. Now, see, you can use calcium channel blocker or calcium antagonists. Okay, like magnesium sulfate. Magnesium sulfate, important point is this magnesium sulfate is having something very good. What is that? It is a neuroprotective. Magnesium sulfate is a neuroprotective tocolytic agent, but this MgSO4 is going to cause hypocalcemia. It's going to cause hypocalcemia and hypotonia. Now this hypocalcemia can cause fractures in the baby. Because of this hypocalcemia, you can see fractures in the baby. Important point, MgSO4. There is one good thing. What is that? It's a neuroprotective for the baby. It's a neuroprotective for the baby. And this MgSO4 is associated with the hypotonia and hypocalcemia, which can lead to fractures in the baby. Now, oxytocin antagonist. Oxytocin is the one which causes the uterine contractions. If you give oxytocin antagonist, the drug which blocks the receptors of the oxytocin, that is 𝗏𝐻𝐵𝐴N. Okay, 𝗏𝐻𝐵𝐴N is a oxytocin antagonist, and this 𝗏𝐻𝐵𝐴N is considered as the safest drug. Okay, this 𝗏𝐻𝐵𝐴N is considered as the safest drug, and this drug will be used in a mother who is having heart disease. This 𝗏𝐻𝐵𝐴N is best in heart disease mother, and this is considered as the safest of all the tocolytics. The best of all the tocolytics is nifedipine, the first line drug, most efficacious drug, but the safest drug is 𝗏𝐻𝐵𝐴N. Okay. Now, see, prostaglandin synthesis inhibitors can be given, prostaglandins, they are going to cause the augmentation of labor. We know that. See, prostaglandin synthesis inhibitors like indomethacin can be used. The important side effect of this indomethacin is this indomethacin can cause premature closure of the ductus arteriosus. Okay, the premature closure of the ductus arteriosus. This is the important side effect, and the maximum fetal side effects will be seen with the indomethacin. And the last point is, see, this nitric oxide, we also know that nitric oxide is a smooth muscle relaxant. This nitric oxide can also be used in the form of a nitroglycerin patches. And last but not the least point, see, progesterones can be used for tocolysis. Can progesterone be used for tocolysis? No, progesterone is the one which prevents the preterm labor from happening. Okay, if a female is at a risk of preterm labor, now this female, now she is having a previous history of preterm labor, and now this female is having a very short cervix, cervical lacerations, this female have under 𝗠𝐞𝐝𝐢𝐚 surgery, now she is at a risk of preterm labor. Now to prevent the preterm labor, we will be giving the progesterones, but progesterones are not going to have any role once there is established preterm labor. So last point is, progesterones is not used as a tocolytic agent. It's just the drug of choice for preventing the preterm labor in women with a history of, in women with a risk of preterm labor, or in a woman with a history of preterm labor. Okay, we have discussed all the important points regarding the preterm labor. Hope the video is helpful. Thank you.